The foundation of medical ultrasound is the piezoelectric effect, which is a relationship between electric and mechanical forces observed in certain substances, including ultrasound crystals. When electricity is applied to a piezoelectric substance, mechanical change is observed. The reverse is also true. Mechanical distortion of a piezoelectric substance causes electrical charge in that substance. This reversible exchange is how the ultrasound machine interacts with tissue to provide images. Each ultrasound probe contains piezoelectric crystals, which have the properties just described. When electrical pulses are applied to the crystals, they rapidly vibrate and produce ultrasound waves. This process exemplifies the forward direction of the association just described in that electricity is used to create mechanical ultrasound waves. These waves then travel into the tissue where they are reflected back at variable times and intensities. Returning ultrasound waves hit the crystals, causing mechanical distortion, which, due to the piezoelectric effect, creates electrical current the machine captures and processes to produce the image on the screen. This process exemplifies the reverse direction of the association as seen on the earlier slide, whereby mechanical distortion of a piezoelectric substance causes an electrical current. Next, there are a few basic definitions that will help explain how the ultrasound machine creates images. These are velocity, frequency, and amplitude. Velocity is the speed of the ultrasound wave, and it is constant in a given medium. Assuming that the velocity of waves is constant, signals that take incrementally longer to return to the probe can be assumed to be incrementally farther away. This is how the ultrasound machine interprets depth of tissues. For example, let's say we're going to ultrasound this kidney. This is what our screen might look like before any waves hit the tissue. To help orientation with the image on screen, you can imagine the probe sitting on top of the screen pointing downward into the tissues, as this is how they will be relayed. The first waves to return to the probe will be those reflected off the top of the kidney, as they have the shortest distance to travel, and we assume all waves have the same speed. The faster the waves return, the closer the ultrasound machine interprets the reflecting tissues to be. The machine will plot these fast returning waves at the top of the screen, representing tissues relatively close to the probe. Waves reflecting off deeper tissues will take longer to return to the probe because they are traveling a greater distance, and we assume that all waves have the same speed. These slower to return waves are interpreted as farther away and therefore are plotted at the bottom of the screen, representing tissue that is relatively far from the probe. The assumption of constant wave velocity is the basis for how the ultrasound machine interprets depth. Frequency is the number of wave oscillations in a given period. For example, this yellow wave represents a relatively low frequency as compared to the purple wave, which has more oscillations in the same period and therefore a higher frequency. Lower frequency waves are better at maintaining energy over distances and therefore achieve better images of deeper structures. This ability to relay deep information is also known as penetration. Higher frequency waves are better at relaying detailed echoes over shorter distances and are therefore preferable when penetration is not a priority, but detail, also known as resolution, is. An example that may help understand this concept is that of audible sound. Imagining a neighbor playing music, it's mostly the low frequency bass notes that penetrate the walls and travel distances well enough for you to hear. The high frequency notes have lost their energy before they got to you, and while the bass notes are audible, the level of detail they contain is minimal. Now imagine sitting right in front of your speakers or wearing headphones. The level of detail is greatly increased by the high frequency sounds, which now have no trouble reaching you over the shorter distance. The frequency of waves created for medical ultrasound purposes depends on the probe and settings used, both of which will be discussed later. Amplitude is defined as the peak deviation of oscillations from the baseline, and for ultrasound is measured in terms of pressure. Think of amplitude as the loudness or intensity of an ultrasound wave. If you superimpose the waveforms from the previous page, you can see that while the frequencies are quite different, the amplitude of each wave is the same. As a comparison, the purple wave with increased amplitude would look like this. You can see that amplitude is independent of frequency, as this wave has the
So here, for example, we're looking at the abdominal aorta, and we want to look at a sagittal view, so the probe marker is facing up towards the patient's head. And if the probe marker is facing towards the patient's head, and it corresponds to the probe marker, which is also this green dot on the screen, that means everything on the green dot side of the screen is also towards the patient's head. Anything on the opposite side of the head is towards the feet. The probe is touching the anterior abdomen, so the top of the screen is anterior, and it's shining ultrasound energy into the body, therefore everything in the far field on the bottom of the screen is posterior. If you stand in a transverse plane and you hold the probe towards the patient's right-hand side, you'll see that everything on the right-hand side, which is the dot side of the probe marker, corresponds to the dot side of the ultrasound screen. So that means that what you're looking at on the left is the patient's right-hand side. The opposite side is the left side. Again, the part that touches the patient is anterior, and the far field is posterior. This should remind you of the normal orientation of a CT scan image. So most of the time when you're doing a transverse view through the abdomen, you're going to get the same orientation in your slices that a CT scan slice in the axial plane will give you. Let's talk about machine controls now for a minute. A lot of the machines that you'll see in your departments are going to be very off-putting because they seem like there are just too many buttons. So let's go back to something that's a little bit simpler. Even though DVDs are going away of the DVD player, I suppose, and very few people know what this thing is anymore because you have Netflix and Hulu, you know that the little square button means stop, and you know that the triangle means play. And this is true in every manufacturer. It's true in every country, in every language. So you can pull one of these guys out of the box, and you'll know power, play, pause, stop, forward, rewind, without having to read the manual. Not true with ultrasound machines. Every manufacturer has a different keyboard layout, different button orientation. It has sliders, it has knobs, it has track wheels. So we need to standardize our interpretation of this a little bit because the manufacturers aren't going to standardize buttons anytime soon. So when you go to your own institution and you look at your ultrasound machine, these are the buttons that you need to figure out. Have somebody show you or read the manual. Where's the power button? Which button lets me select a probe? How do I control the gain, the depth? And how do I freeze and save images? How do I store these images for later use? Maybe you'll want to know how to press the print button because you have a printer attached. The idea is how do you save the images? So gain is basically the volume knob on the machine. It controls the amplitude of the signal. So on the left we see the image is too dark, on the right we see it's too bright, in the middle it's just right. Just like any good black and white photo, there should be black and white in shades of gray visible in the image. Depth controls how long the machine listens inside the body. The longer it listens, the deeper basically the machine can send that ultrasound energy. So we want to see structures that we're interested in. We want to see them completely, but we don't want to see anything extra. So here, for example, there's an image of liver and kidney. And here it's too small, and there it's too big, and maybe in the middle somewhere here it's just right. So you want to change the depth to the point where you can see the entire structure you're interested in, no more, no less. If you're interested to see how deep you are, in the bottom right-hand corner on almost every machine, there is a total depth. So this machine, for example, goes from 10 centimeters all the way up to about 24 centimeters in depth, and that means that each of these little white dots on the right-hand side of the screen represents 1 centimeter. And again, here on this machine as well, we can see the centimeter marks and the total depth on the bottom. Some different axes that we image the heart through. A long axis, which runs along the long axis of the heart from the atria to the ventricles and out through the tip of the apex. That's in this cyan-colored box here. A short axis is also commonly used to assess cardiac contractility, looking through the ventricles, and that's this yellow plane that you see drawn here. And finally, a 4-chamber view, again, very commonly used in cardiology, intensive care, emergency medicine, and other specialties. That's this green plane here, and this cuts through again, a 4-chamber view of the heart where you can see both atria and both ventricles. The cardiology convention, when you're in cardiac mode on the ultrasound machine, is that you're going to have the probe marker, again, either up towards the patient's head or off to the patient's right-hand side. The This varies a little bit between ICU, emergency medicine, cardiology, and when you do a hands-on ultrasound experience, you can go over the different conventions with the instructor. So, placing the probe marker towards the patient's right-hand side and the probe itself in the subxiphoid view, we get to see this subxiphoid four-chamber view. This was the same view that we were using before to demonstrate the window. And the window here is the liver. So the fact that I can see a little bit of liver up here in the near field means I'm going to get a good picture of, from anterior to posterior, the right ventricle, the right atrium, the septum, left ventricle, left atrium, and in a really good four-chamber view, you'll be able to see the tricuspid valve and the mitral valves as well. This is a schematic demonstrating where we're slicing through the heart and the schematic of the chambers that we would normally see. And this is what a normal subxiphoid view should look like. We can see that the heart muscle is contracting towards the center of the chamber pretty well. We see that all four chambers are moving. We can see the border of the heart here, the pericardium, that it's bright white and that there is no fluid within that pericardial sac. And we can see that the fluid inside the heart is black, as it should be, which means the machine is calibrated well. You see the liver is gray, the inside of the atria and the ventricles are black, and the pericardium is white. So the dynamic range on this image is very good. Another very commonly used view is a parasternal long axis view, holding the probe along the long axis of the heart. The cardiology orientation would be that you would hold the probe marker up towards the patient's right shoulder, but the plane of the ultrasound beam should be along the long axis, so it extends out towards the apex. And when you do that, you're basically using the chest wall as a window, and you're looking directly down into the RV outflow tract anteriorly. Deep to that, you see the septum. Deep to that, you see the entire left ventricle with the LV outflow tract and the aortic valve, anterior to the mitral valve and the left atrium. And notice this gives you a picture, when you hold the probe marker up towards the patient's right side, it gives you a picture that is opposite in terms of left-right orientation compared to how the patient's oriented in real life. And this is just a consequence of a cardiology convention that started back in the 1970s, where patients used to be imaged from the patient's head. So if you were facing the patient's feet, you would have the patient's left ventricle towards your left side, and therefore on the screen you would have the left ventricle or the apex towards your left side as well. As we grew towards moving towards imaging patients facing them, we kept that convention. So depending on where you then turn your probe, you can take a long axis view that we see pictured on top and rotate into this short axis view, which is through the mitral valve, the left ventricle, and the right ventricle. If you go a bit more apical towards the edge of the heart, you'll see a view of the left ventricle with the papillary muscles and the right ventricle on top. And if you go towards the base of the heart, or the annulus fibrosus, you'll see a bit of the RV outflow tract here, and the aortic valve, and the left atrium in this view. So depending on what you're looking at, you can slice different short axis views. So let's just take a moment to look at contractility. There are three things we want to focus on for contractility. One is, are the walls all coming together pretty symmetrically towards the center? So this little hand now is in the center of the left ventricle, and we can see that both the septum and the posterior wall are coming together symmetrically towards that center. So that looks pretty good. The next thing is this heart muscle thickening as it contracts? Because there's no difference between septum and bicep or quadriceps muscle in the sense that when it contracts, it should thicken. So we see that every time systole is happening, the muscle is contracting and thickening, and the posterior wall is contracting and thickening. Scar tissue won't do that. So that's another thing to check for. And finally, since we know that the amount of blood coming into the heart during diastole should equal the amount of blood going out of the heart during systole, if we can tell that a bunch of blood is coming into the heart during diastole, then we know that there's a good ejection fraction. One way to look at this is to look at the separation of the septum up here to the anterior leaflet of the mitral valve, which is down here. And we look at the septal separation during the E point of the cardiac cycle, which is the point of atrial kick. So the latter part of diastole, when the mitral valve opens wider, we want to see if the mitral valve gets within a couple of millimeters of the septum. And here, for example, we can see that it's actually touching the septum. So again, E point septal separation, or EPSS, on its own can be a good marker for ejection fraction. So we're not only looking here to see that there's no pericardial effusion, no blackness outside of the heart in the pericardium. We're looking to see that the ventricle contracts symmetrically towards the center and that the valve is opening wide open during diastole. So this is a good ejection fraction. We're also looking for effusion. So here, for example, we can see the heart beating in the center of the pericardium, and there's this large black stripe of fluid all around it. This is pericardial effusion. And we can see, even as the operator here is moving a bit more toward the apical view, we can see that there's fluid surrounding the heart. When that fluid creates enough pressure around the heart, we'll start to see tamponade, and that will create a pressure on the right ventricle, which is a lower pressure ventricle, and we can see that this area here anteriorly, which should we should see the ventricle going out and in as it contracts and expands during systole and diastole, and instead the amount of pressure on it from the outside is forcing it downwards. It's been described by some people as a heavy kid on a trampoline. And here, in this case, it looks like the trampoline is not rising up at all. So we see this large effusion, which should mean for tamponade, and also the fact that the right ventricle is almost entirely obliterated by the pressure. And here, even though the view of the heart is not very good, we can see a heart that's trying very hard to beat. We can see ventricles that aren't opening very well, that aren't able to fill, and we see a very large pericardial effusion. So this subxiphoid view, the heart looks like a little fist trying to contract, and the pressure around the outside of it is just too great. So this is another very flagrant example of tamponade. And here we see tamponade with the heart swinging back and forth, and that swinging back and forth should remind you of the variable QRS complex amplitude that you will sometimes see with pericardial tamponade. You can imagine that the rhythm strip on this patient will show a taller and then a shorter and then a taller QRS complex as the heart swings back and forth. So let's look at another couple of examples of cardiac contractility here. So here we're not seeing much motion towards the center of the ventricle. The walls aren't moving very much. You're seeing almost no thickening with the contractions during systole. And the mitral valve itself here is barely opening. This is the anterior leafle of the mitral valve. This is the part of the septum that it should be nearly touching. So we see the E-point septal separation in several centimeters as opposed to being just millimeters. So this is very poor contractility that you would see with a patient with congestive heart failure, some of the scarring after myocardial infarction. And here again we see another heart that looks like it's working pretty hard to beat, and when you look at it at first it seems like it's doing pretty well, but then you see that the septum here is only sort of moving back and forth. It's not really thickening as it contracts. There's not a lot of organized motion towards the center of the ventricle, and the mitral valve again is only getting about halfway in between the posterior wall of the ventricle and the septum. So there's poor E-point septal separation, there's poor concentric contractility, and there's very poor thickening with contraction. So again, another example that might fool the eye at first, showing you poor contractility. In contrast, here we see a hyperdynamic heart. This is a heart that does not have enough fluid to work with in a patient who is probably fluid depleted, or might have sepsis. So this patient either has an absolute or a relative volume depletion, and they're going to respond to fluids a lot better than they're going to respond to isotopes or chronotropes. And So we can see that the muscle is thickening. There's a lot of movement towards the center. The walls of the ventricle are almost touching each other, and the septum is practically being slapped by the anterior loop of the mitral valve here. So this is a patient who, if they've already received some fluids in your initial resuscitation, they need more fluids. And here we see a similar patient with a hyperdynamic heart. This is a subxiphoid view where we see all the ventricles working really hard, contracting very well. They just need more.
first finding in pregnancy, and that is a gestational sac, seen to the left in long axis and to the right in short axis. Note the presence of a small dark or anechoic sac located within the fundus of the uterus. Now, the gestational sac can also be seen in a pseudogestational sac of ectopic pregnancy and thus is not diagnostic of an intrauterine pregnancy. However, it's an early finding of pregnancy seen at about 4.5 to 5 weeks on transvaginal sonography and a week later on transabdominal sonography. So what defines an intrauterine pregnancy for emergency physician sonographers? Well, here's a video clip showing the gestational sac, larger on this video, and notice the presence here of a yolk sac, that circular round structure lovingly referred to as a Cheerio sign within the gestational sac. Once we see a yolk sac within a gestational sac, that is diagnostic of an intrauterine pregnancy. And the yolk sac is generally seen at about 5 to 5.5 weeks on transvaginal sonography and a week later on transabdominal sonography. Here's a pregnancy that's a little bit more advanced, and here we see a large round gestational sac, that dark or anechoic structure, and inside the gestational sac we can see the circular yolk sac or Cheerio sign. And let's look just to the left of the yolk sac here, and now we appreciate the presence of a tiny fetal pole. Interestingly enough, when we magnify the fetal pole, we can actually see a tiny heartbeat. Now, the fetal pole is generally seen at about 5.5 to 6 weeks on transvaginal sonography and 1 week later on transabdominal sonography. Here's a video clip from a patient who had a twin pregnancy. Notice the presence here of 2 large gestational sacs, and within each gestational sac we can appreciate fetal poles, and notice that each fetal pole has a heartbeat. So we see dichorionic twins, twins with separate gestational sacs, each with fetal heart activity. As a general rule, fetal heart activity is seen at about 6 weeks on transvaginal sonography and a week later on transabdominal sonography. Here's a 7-week intrauterine pregnancy on transvaginal sonogram. Notice here the presence of a large gestational sac, and importantly, note the rim of uterus that surrounds the gestational sac. We see the circular yolk sac anterior, and note the fetal pole with well-developed cardiac activity. Now we note here another structure, which is the amniotic membrane, billowing out from around the fetal pole. Eventually that amniotic membrane will close down at the outer margin of the gestational sac, forming the amniotic cavity. Here's a transvaginal sonogram of a late first trimester pregnancy. And as I work in northern Manhattan, we refer to this as the merengue baby. And note the arms and legs moving fluidly to the merengue music, a sure sign that this kid will be a slick dancer.
sonographic window. So remember, our sonographic windows are anywhere where you're going to put the probe on the patient, and it's going to allow us that window to look inside the body and evaluate what's going on. So we have here first our peristernal, apical, and subxiphoid. And I like to go in a clockwise manner. I like to start at the peristernal, go clockwise, apical. Try to make this the best image I can. Now of note, if you have somebody that does have a lot of abdominal obesity, that will push the heart up a little bit, and you may see it higher. If they have COPD or their history of smoking, you may almost feel like you're in a subxiphoid view before you find this peristernal long axis. And be patient. This is probably, this is one of the harder studies to develop that technique of looking through the ribs and really seeing what you need to see. When we look at the peristernal long axis, this is what we want to essentially focus on. We want to get the left ventricle. We won't always see the apex, but we want to get it elongated out so it's not blunted, it's not curved here. And we really want to pull in the mitral valve here. We want to be able to see that. That tells us essentially we're in plane. And when we look at our anatomy, we're just going to remember that the right ventricle's a nice tubular structure, but the right ventricle just kind of wraps around it. And here we truly only see kind of the right ventricular outflow tract as it's going up to the pulmonary artery. We've got the base of our heart here, and we've got the aortic root, our descending aorta, and left lung. And I like to think of it this way, is look at where the arrow is pointing if you're struggling to remember what things are. So look at your big, meaty chamber of the heart, and that's typically going to be your left ventricle most of the time, unless they have other pathological issues, but most of the time it's going to be your left ventricle. And then just look where arrows point to and from it. You've got your mitral valve that's going to be flapping into it or pointing into it, and you know that blood's going to be coming from the left atrium. And then you can see it, you'll see an arrow kind of pointing out and away from it, and this is going to go to the aortic root. Just knowing that, you already have 3 of the structures defined. And then because you're at the level of the ventricle, you know that your right ventricle is going to be right there also. And then remember that the descending aorta is outside of the pericardial sac. That will help you know that if you see a fusion come down and it goes anterior to the descending aorta, it's in the pericardial sac. If it comes down and goes deep to it, it's in the left thorax. So if we see a live film of this, this is what we see going on. We've got our big, thick, meaty ventricle here. Here's our mitral valve flapping into it. We see nice compression. This is collapsing well. We see that this outflow tract, or this is pointing away from it. This is the aortic root. So we have left atrium, and then we've got this descending aorta back here, and then we can remember our right ventricular outflow tracts here. And I'll come off that just a second so you guys can see that well. But this is a normal functioning heart. If we apply those binary questions, this is a normal appearing heart here. When you're in the peristernal long axis, don't lift your probe off the patient. Take your image, whatever you're doing, video clips or still images, and then leave your hand there. Leave it on the chest. Don't take it off because you'll have to find it again, because your next view is in that exact same sonographic window. And we want to rotate our probe clockwise 90 degrees. And that's going to put us somewhere between the mid-clavicle on the left to the left shoulder, typically anywhere between 1 and maybe 3 o'clock, depending on the body habitus. And that is what that's going to do, is it's going to cut the ventricle into, or we're going to see that cylinder shape or that circular shape of the left ventricle. So we're going to end up with an image like this. We're going to have anterior to posterior. We're going to see the left, or a little bit of the right ventricle wrapped around the left ventricle. It's not going to have the big, nice thick wall that the left ventricle has, or it shouldn't in a normal patient. And for beginners, I like to just have people focus on getting it just distal, or aiming their probe or fanning their probe a little bit to the apex, just past the mitral valve, so they see the papillary muscles. Some of you may get to the point with some advanced scanning of looking at the mitral valve, but for the majority of you that are just looking for what is the cardiac function, this is a good shot to get an idea of what's going on. And you want to see these papillary muscles. They'll show up as 2 hyperechoic structures within the left ventricle, and it gives you a good idea of what the squeeze is of the left ventricle. So let's take a look at that here. So we see that nice thick ventricle. Looks like a donut almost, with these 2 little eyes in it, or hyperechoic structures. And I just like to imagine a little dot sitting right here in the middle of that structure. and what is going on with that, and how much collapse is there. Now, when you evaluate this and you're thinking of this, a lot of novice people or novice practitioners to ultrasound will say, well, it's not collapsing all the way. And you got to remember that a normal ejection fraction is above 50%. It does not have to collapse all the way. If those walls are touching each other, that's a hyperdynamic heart, and that's not normal. We want to see that space decrease by 50%. And you looking at it and just saying, you know, this is what it looks like, is pretty good as you get experience of evaluating what the EF is. And we want to just refer to it as normal, and if not normal, is it severely depressed? And in between, we're going to call it reduced as we do basic cardiac ultrasound. Now for the apical, remember, we're going to pick that probe up off the patient, and everything we do in cardiac ultrasound is rotating on clockwise, and we're moving the probe clockwise. So we're going to lift that probe off the patient. If you can feel for a PMI, great, but typically it's going to be right in the true nipple line. In women, it's going to be right up under that breast flow. You're going to want to displace the breast up, and men kind of get down under the pec muscle and go right and those ribs, and you'll feel a little space there. And put the probe there. You're going to rotate your probe marker to about the 3 o'clock position. Sometimes you'll have to rotate maybe 2 to 4 o'clock depending on the angle of the ribs and what the heart's looking like. But we're going to end up with a view somewhat like this, and it's an apical 4-chamber. There are some other apical views, but for the basic cardiac ultrasound, I would recommend just doing apical 4 for now, until you get some experience. And we should see, if you're not seeing all 4 chambers, you need to fan, you need to rotate, you need to optimize that image to see it all, because this image is a little bit harder to obtain than the other cardiac views, but it is definitely worth it because it gives you a lot of information as you watch it. And I will tell you though, also, because this view is a little bit different, I have people underestimate the ejection fraction quite often on this. So get used to seeing this view. It's a little bit different than the others, but it does provide a lot of information. So we're going to find our big left ventricle here. It's going to be nice and thick, and then we're going to have our right ventricle kind of over here. It's going to be thinner walled, but they'll be at the same level. And then just remember where are the valves pointing, and those are going to be your atria above them. And then occasionally you'll see your descending aorta sitting right up here above the left atria. And then remember, everything kind of surrounding is your left lung. Now, when you look at this view, please remember that the apical view is the least sensitive for finding pericardial effusion. Now, if it's a large pericardial effusion, absolutely you're going to see it. But if it's a small trace effusion or trace pericardial sac fluid, you will not see it because it could just be in a gravity dependent portion, and you may not be visualizing it on this image. So if we go to an ultrasound here, we can see this left ventricle. It's nice and thick. We can appreciate this little inner wall here. Valves flapping up in there. It's collapsing well. This image, the gain could have been a little bit better distributed. It's a little bright down here at the bottom, but we can appreciate the left atrium, right atrium, and we see our right ventricle. Right ventricle should be about 60% or 0.6 compared to the left ventricle. Some people say it can even be acceptable up to 1, but I personally, once it gets up to they're looking the same size, I consider that to be some right ventricular hypertrophy, or not hypertrophy, but dilated right ventricle. Subxiphoid, we're going to continue to move the probe in a clockwise manner. This time we are not going to rotate the probe. Now, don't let this confuse you. For those of you that have listened to the FAST lecture, our probe marker's towards the right, but you got to remember, we've switched to cardiac setting, and or at least most of you will have switched to a cardiac setting for this. And when you do, your probe marker and your probe indicator are going to be a little bit different. So on a cardiac setting, you're going to leave your probe marker pointed towards the patient's left. That's still that 3 o'clock position. And then you're going to aim, push down with pressure first, keeping that probe perpendicular to the skin. Once you push down a ways, and slowly so they don't feel like you punched them in the stomach, then you're going to turn your probe and aim it up towards that left shoulder. And once you get up to that left shoulder, you're going to get a view that looks like this. You'll see your liver. See, you're going to use that as a sonographic window. Your right ventricle will be laying on top of or right underneath that. and at the same level will be the left ventricle, and you'll see that nice big thick meaty wall, and then you'll be able to tell where your valves are and where those are pointing to and coming from, and that will define your atria. So let's take a look here at an ultrasound image of that. So we see this nice big thick wall right there. Over here, this is our left ventricle, all right here. Our right ventricle is going to be here. It's very small on this image compared to the left ventricle. Definitely not as thick walled, but this is our same level, so that helps us define them. And then we just watch these valves that are flipping up into the ventricles and know that those are the atria lying beneath them. So this is another 4-chamber view, and this is a good view for determining if there's pericardial effusion. I don't find this, sometimes this can be very helpful for estimating ejection fraction, and especially COPD patients, but sometimes obese patients this can be a very difficult view, so don't get too frustrated if that's an issue. Now with the IVC, we're going to keep our probe in essentially the same place. I'd let off on your pressure, stand it up, and now you're going to rotate the probe marker towards the feet. And staying right in the middle, you're going to fan over and look at the patient's right side, and as you fan across, you're going to be looking at the liver, and you're going to come across till you see the IVC. And we want to see, because of this plane, because you're in the middle, you should see liver on it on this side. Now the IVC does course behind it, but as you go from midline over to the right, you are going to capture this right lobe of the liver behind the IVC. And another thing to help you determine this is the IVC is the hepatic vein coming in. Now the reason why I say look for liver behind it and here the hepatic vein is because a lot of people stand it up, look straight down, and they'll see that aorta right underneath there, and they'll determine that to be the IVC, and they don't appreciate any collapse, and they interpret that as being a dilated or high CVP on the patient. Please be careful of that. That's a novice mistake. Just make sure that you're looking over and seeing at least the hepatic vein coming in or a little bit of liver behind it, and really focus on if that's the IVC or the aorta. So here we can see this image here. We can see the variability. We have a little bit of, you have the pulsations from the emptying of the atria, but you can also see that here the patient's breathing, and as that decreases the intrathoracic pressure, the IVC is able to empty a little bit more into the right atria, and that gives us some respiratory variation. And as you know, you can see some right lung here, so you may see a pleural effusion or right thoracic fluid occasionally on this view. So there are several tables out there that describe this. This has been well described, that you can determine a CVP, take the pitfalls of using a CVP and determining what a volume status is or fluid responsiveness. I'm not going to go into detail of that, but respiratory variation can help you know what a CVP is, at least. I kind of look at it this way. I struggle to memorize this table. I look at it as a slit-like and collapsed. If it is, I've got a low CVP. If it's dilated like this one and has some respiratory variation, which this is probably close to 50%, then they probably have a normal to normal high CVP. If it's dilated without collapse, or less than 50% collapse, then they've got an elevated CVP. And if they have a dilated IVC without any collapse, then they have a significantly elevated CVP. And I think that's just easier than always coming back to this table. Now, some of you may be calculating a collapsibility index, and that's great. And for this, the aspects of this lecture, we're just talking about variation and how that